Hello, everyone, and welcome to the Savvy Cast. This is Jamie, and I'm so glad that you're here, whether you're watching on YouTube or listening to the podcast. I have a visitor who has been a guest previously and very successful podcast with Dr. Chelsea Aldred. He is an OBGYN here at OBGYN South in Birmingham. He's a native of Birmingham. Justin, thank you for agreeing to come back. You're very busy, and this means a lot that you would come.
Yeah, thank you for having me. I'm looking forward to it. Thanks for having me, and I love your podcast.
Oh, you're so kind. And he and I were just chatting. They're neighbors of ours. His precious wife, Chelsea, is a doll, and precious children. And you tell them how y'all celebrated Easter. I think that's so sweet.
Yeah, it's funny. Well, a lot of times when I'm on call with my practice, and I was on call this Easter, and it was great. Always have the kids up to the office, and we've got about 13,500 square feet for the kids to run around and play hide and go seek. And so that's something that they love doing. And so it was a great time. It's a lot of space to hide in, so it feels like a kingdom to them. So it was fun.
Did you have an Easter baby that you delivered?
Had quite a bit. Yeah, I think I delivered it 8 or 9 this weekend. And so we had quite a few babies born. I can't remember who was the first to bring in the Easter delivery, but we had quite a few. So it was a busy weekend.
That is amazing. That would be a special birthday to be born.
That's right.
Easter. Wow.
That's right. Sure would.
Well, I'm going to skip the icebreaker question because I asked you the last time you were on, and I have to tell you.
Yeah, how was it?
That is now my new favorite restaurant.
Okay, good. I'd like to hear that.
Bistro. I always get the
218.
Boy, we're very glad you shared that tidbit. It's
a good one.
Phenomenal atmosphere and food. So thank you for that.
You're welcome. I'm glad you enjoyed it.
Okay. Well, everyone, Justin, Dr. Aldred is here to talk specifically about women's health and hormones. And I did not put a question box up probably soon enough. I did about an hour ago, and there are already myriad questions. So this is obviously something that people are very thankful you're addressing. So I'm going to let you start by telling us what we need to know before I just get to all the different questions, because there's probably an overall philosophy that you have and just medical advice about hormones. And I will just tell you that from the older ones in the 40s and 50s, a lot of questions about menopause.
Yeah, sure.
No sex drive.
Yeah.
And then with the youngers, we're getting into some non-hormonal birth control. So I'm just going to let you dive in, and then we'll take questions.
Well, man, I got the email to do the podcast, and it said hormones, and my heart kind of, wow, that's a big topic, but an important topic. And I think we have, it's a big ocean of information, and a lot of it's difficult to wade through for people. And hormones are, obviously everyone has hormones, specifically female-related hormones when it comes to menstrual cycles, and then when you transition into menopause, it's a big topic. It requires, I think, a lot of personalized care to individual needs. So it's not a one size fits all for everybody, and it's kind of like pregnancy, right? You have one patient who's gonna tell their friend how their pregnancy went, but then that friend's pregnancy goes in a totally different way. And I think that's the same way with cycles. I mean, God has created every individual differently. And obviously there's problems that arise through a woman's life that can become bothersome, and it can affect their quality of life. And unfortunately that doesn't end when menstruation ends. That actually continues on into that postmenopausal period. So, I'm actually excited. I would love to hear questions, and then we can kind of address those questions. And I think that might lead down some good topics and good conversation.
Okay. So what I'll do is I will start with some questions about hormones for women in perimenopause and menopause.
Okay. Yeah.
And I had a specific brand that someone wanted to ask about, and then I'm going to toss mine in there because I've been taking it. And before I even knew you, I've had my doctor, Greg Banks. I've had him. He delivered Emma. He still takes
Yeah.
care of me, but I've been taking compounded. So I
Yeah.
take Progest, which
Yeah.
is compounded. So can you just start with that? And then this other person is taking something called Imvexi.
Yeah. Invexi. Yeah.
Uh-huh.
Yeah.
And she's concerned because she said, I could not have sex if I did not take this, but I don't think it's compounded. So can you
Yeah.
look at compounded and not, and what's your
Sure.
thought?
So, when we talk about hormonal replacement, I think it's wise as a patient and as a woman, especially as you're going through and transitioning from that perimenopausal to postmenopausal state, that you have this conversation with your physician. And most physicians will feel comfortable and certainly should, as an OBGYN, discuss these symptoms that arise as you enter into this phase of life. By far, as a menopausal symptom, the most common, up to 70% of women who transition into menopause will experience what we call vasomotor symptoms. And those are the hot flashes, those miserable sweats that can take place at any moment and kind of make you feel like you just took a shower and you're soaking wet. And obviously that can cause marked problems with quality of life, and no one wants to be in mid conversation or doing something and just feel like they have a sweat breakout, or maybe they wake up in the middle of the night and their sheets are soaking wet. That's by far the most common symptom that arises. And then right behind that, probably the second most common thing that we see and see this clinically and hear about clinically is vaginal atrophy or vaginal thinning of the vaginal mucosa or the lining of the vagina. And so those two things are probably the most common things that we have to tackle as gynecologists when we treat this age group. And by the way, average age of menopause is 51, and you can fall really on either side of that. I have plenty of patients that are a little bit less than 51 that have gone through that transition, and those who are older than 51 that have gone through that transition. Now, as far as your question as, okay, now we have to think about treatment options. And as a clinician, I think we're trained, especially in my day and age, not to go straight to these bioidentical hormones, these compounded pharmaceutical hormones. And the reason is because compounded pharmacies or compounded bioidentical hormones, for the most part, are not very well studied. They have an unpredictable dose, and they are, once they are implanted, especially in the form of pellets and things like that, they really don't have, you can't take them away. And so, listen, I use them. I use bioidentical hormones in the right patient. My partners use bioidentical hormones in the right patient, and they are extremely effective at relieving vasomotor symptoms, vaginal atrophy. And we can actually incorporate testosterone, which is something that we can talk about later in terms of like low libido and things like that in the primary treatment for low libido. So there is certainly a place for these compounded pharmaceutical companies and things like that to manufacture, but we do need to know that they are not FDA approved, and they will likely never be FDA approved because they lack adequate studies. They also lack an accurate dosing as well, and typically they're given as kind of an isolated dose. They're given to the patient. Now there are companies, very reputable companies, and I know Dr. Banks uses this as well, that actually do tiered dosing based on symptoms, and they actually monitor the patient's hormonal functioning throughout that time frame when they have these bioidentical hormones.
Is there a name for that, or is there a specific brand, or can you say the company?
I'm not familiar with the exact company, man. I wish I would have asked him before. I don't know his exact company, but I know if you get on Google or whatever, you can look up some pretty reputable companies and some ones that are actually local here in Birmingham as well. We use some pharmacies here, and a lot of kind of private pharmacies will typically be able to use or will be able to compound specific hormones. And we have a way of doing that within our own office. We use pellets quite a bit, or different types of creams, or even patches for that matter.
Mm-hmm.
And they are very, very effective. They do help. But I will tell you, as a practitioner, that is not my first knee-jerk reaction to go immediately towards those bioidentical hormones, because of the lack of FDA approval. I think it's safe, and I think it's good to maybe consider some of the FDA approved, on the market, well-tested products that have been out for a long time. One of the products that you mentioned was Imvexxy. So that's more for vaginal atrophy. So Imvexxy is kind of more of a
May I interrupt you just in case someone has a question? I know atrophy means wearing away, but does that encompass dryness and thinning and pain?
Exactly. So sorry about So vaginal atrophy is in premenopause. The vagina and the vaginal tissue is very sensitive to estrogen, and it requires estrogen in order to maintain its thickness and its healthiness of the tissue. And so when you typically go through that menopause, you get the withdrawal. Now your ovaries have shut down the production of estrogen, and therefore estrogen is not having that positive effect within the vagina. And so what you'll see over a period of time is you'll start seeing a much thinning of the vagina. You'll start seeing narrowing of the opening to the vagina, the introitus. And when you do these exams, you can tell immediately, and you'll see the labia, which is the larger lips of the vagina, and also the labia majora and labia minora will be kind of starting to fuse together. And then that can create a lot of discomfort. We call it dyspareunia, or painful intercourse. The dryness is a major issue with that, as well as you can end up starting to get bleeding from intercourse as well because of such thinning. I've seen patients have significant bleeding with intercourse with severe atrophy. And so there are multiple products that are out on the market to help with this. And I will tell you that oral systemic therapy is very effective at treating both vasomotor symptoms, the hot flashes, as well as the vaginal dryness. But we do know that local therapy is much more effective than systemic therapy when vaginal atrophy is the primary symptom. And so if I have someone that comes in and their primary symptom is painful intercourse or vaginal dryness, and I do an exam and there's obvious evidence of atrophying, and they're not experiencing hot flashes, then my first go-to is typically going to be more of a localized vaginal estrogen. And the good thing about that is there's limited systemic absorption. There's not a whole lot of risk with having vaginal estrogen. Now, obviously, you want to talk about breast cancer risk and things like that, breast cancer history. You want to know a lot about kind of their past medical history, but for the most part, most women are very good candidates for localized therapy vaginally, and it can be very effective. Yeah.
Okay. Let me ask you, is a suppository is that the same, a suppository or a cream that you would insert with either an applicator or?
Yeah.
Okay. So that's local. Okay.
That is local. That's correct. So Imvexxy is one of those that is a vaginal kind of a pill insert. It's like a teardrop looking a pill that you can actually place within the vagina. And it's almost like an oily substance. You can place it at nighttime, and then you put on a pad, and then you can put on a panty liner, and then it gets absorbed locally in the tissue. And over a period of time, you can start seeing significant improvement. Now, I'll tell you, there's Premarin, there's estrace cream. There's actually something called Osphena, which is it's a separate type of medication, which over the past probably 5 to 10 years have become more popular. It's called a selective estrogen receptor modulator. So it's an oral medication that you can take, but you take it by mouth, and it actually has a positive effect vaginally to help reduce painful intercourse and vaginal dryness. And it's expensive. It can be expensive depending on your insurance coverage, but it's actually a good proven medication and also has FDA approval.
Now, I took this for a while, and then Dr. Banks said that in his watching his patients, he said that he has found that you can get results by taking it I think 2 or 3 times a month instead of every day. Intrarosa.
Yeah, so that's actually, yeah, it's great. That's what I was going to bring up.
Okay.
So intrarosa it's prasterone. So actually, it does get absorbed in it. You have a little bit more absorption systemically, and there is a conversion into an estriol. So it's an estrogen, and it also has some testosterone component there too. That in some studies have shown some improvement in libido. I'll tell you, I read a study recently that showed that intrarosa, now it's actually, as prescribed, it is a nightly suppository placed in the vagina. And I read a study recently that actually did a head-to-head with some of the traditional vaginal estrogen creams. And they did it by biopsy. They actually did pre-treatment biopsies of the vaginal tissue. And then after they've been on it, I can't remember the exact duration, maybe 8 to 12 weeks, something like that. Then they did another biopsy, and they showed that intrarosa had significant improvement over that of your local estrogen, vaginal estrogens. And so I love intrarosa. I've had good experience or good results with it. I've used it on quite a few patients. It is different from your Primarins or your esterase creams, where it's typically kind of as prescribed as the company would like you to prescribe. It would be at every night type thing before bed. But yeah, you can certainly space that out and kind of tailor it to your own liking as well. And that can be helpful.
Well, and it may have gone down, but it was not the least expensive drug that you could buy. For a while, it was over 200, and then I think it's gone down, and
sure.
Which I don't know, because I use the Progest, which can you address? And I know I've got so many other questions, but Progest, I believe, has estrogen, testosterone, and
progesterone. Do you take that orally, or is it vaginally?
I have cream. It's in
cream.
Like a syringe. It's compounded, and I feel great pretty much all the time. So it must be working, but isn't it like several hormones in one?
Yeah, I think that has progesterone, testosterone, and estrogen.
That's
especially
right.
in women with uteruses. One of the most important things that you need to know is when you have a uterus and you've not had a hysterectomy, it's extremely important to have not only estrogen, but you do actually need progesterone on board as well to help protect the endometrial lining. Because how a cycle works, obviously, is in the first 14 days of a cycle, premenopause, you get that predominant estrogen. And then that second half of the cycle, then you predominantly have the production of progesterone. Progesterone is extremely important to help counterbalance the estrogen effect on the uterine lining. And if you're menopausal and we just give you pure estrogen and you have a uterus, you can actually, it's like over fertilizing or watering the lawn without mowing it. You can actually get an overgrowth of the lining of the uterus, and it can eventually result in the formation of hyperplasia or precancer of the uterus, and then eventually uterine cancer. So anyone who has a uterus does need a combined estrogen and progesterone, and that's why what you are on now has that component. Now, one thing that we do need to know too, there a long time ago, back in I think it was the 90s, the Women's Health Initiative was a big study that was done that really, it wasn't a great study, but we did learn a lot from it. And one thing that we did notice is that breast cancer risk actually increased in women who were on the combined estrogen and progesterone, and we did not see that in those patients who were only on estrogen. And so, that combined progesterone estrogen it's a wonderful medication. It's just one of those things that I think whenever we counsel patients, we do have to talk about. Whenever you're on hormone replacement therapy, I think it's important to talk about those risks of breast cancer and also, like what we talked about in our last podcast, is venous thromboembolisms and blood clots and things. And so those are things that I think most physicians will have to discuss individually with their patient. But back to your question about what you're taking, I think that's a wonderful compounded cream. It provides you with that controlled dose of estrogen, progesterone, and testosterone. And testosterone is kind of one of those hormones that's coming on the market a lot now. And there's some studies, and again, no FDA approval for the utilization of testosterone in women with low libido or low energy level. however we use it, because we do see clinically that it's effective. I'll tell you that we do pelleted testosterone. We do cream testosterone. I read a recent study that showed that the transdermal route, whether through a cream or either through a patch, the study showed that women that received the most benefit from the testosterone were actually reaching levels at the lowest end of the male testosterone level. Women on a day-to-day only have 1/10 of the testosterone that men have. And so in order to get them to that lower level, you're actually having to place patients. And I think this study used a 300 microgram transdermal patch to be placed. And that provided women with significant improvement in libido, sexual satisfaction, and also energy levels as well. And like I said, I think when you're starting to get into the compounding nature of doing these things, it's an art. I think you have to learn, and I'm still learning that process as well, individualizing to each patient and their needs. Mm-hmm. It's amazing how much, so, we do this a lot of times for postmenopausal women, but man, for premenopausal women who are, outside of, it's kind of a lacking, honestly, there's a big wide open market that's just not been tapped into to effectively find medications that are really have a high success rate with an improvement in libido. And so it's difficult more in the premenopausal.
Well, do you think, but am I hearing you correctly in that a testosterone patch mm-hmm. helps most women have a better libido, and that they should not, like the person who's just taking the Imvexy would benefit from taking some testosterone as well?
Yeah. And I've got to be careful, yes. I mean, clinically, yes, you see improvements. Every patient that I've ever placed on any form of testosterone has received improvement in their libido and have reported that to me over the years. And I would say that's the same for most of my partners and Dr. Banks and mm-hmm. everybody. Yes, I think it would certainly be a discussion. Again, testosterone has risk involved with that. One of the things that you have to know about testosterone is that it can elevate your triglycerides and cholesterol. And so in women with pre-existent hypertension, diabetes, or hypercholesterolemia, that they need to be cautioned on being on testosterone. And a matter of fact, I would really not want to place patients on testosterone for that reason. But yes, I think, certainly if someone is experiencing vaginal dryness and then also having or experiencing low libido, then testosterone certainly could be in the conversation as long as the patient understands the risk.
Okay. And I'm looking over questions. Is it normal for women age 30 to have no sex drive? Most women of that age probably are what? Perimenopausal, if even that.
Sure. And I think, so man, there's also some studies out there that show that the absence of sex drive or low libido is present around 14% of women who are premenopausal. And that number is probably a little higher than that, to be honest with you. And I think it's multifactorial when you get into low sex drive in a premenopausal woman, especially in light of having normal hormone. We oftentimes overlook the emotional, some of the things that are going on behind the scenes. So one of the first questions I'll ask is, hey, how is your relationship? How is that going? If they say, man, it's going great, we have a great relationship, I think it's important at that point, review the medications that those patients are on. Mm-hmm. There are many selective serotonin reuptake inhibitors, SSRIs, things like Zoloft, Lexapro, Celexa, Paxil, Effexor. These are medications that can actually lower and have a significant negative impact on libido. And they're very important to treat, generalized anxiety disorder and major depressive disorder, but they actually have a significant negative effect on their libido.
I think it's recommend one? Yeah. And I don't want to interrupt you, but I'm just in full disclosure, I'm very open. I have like a tinge of ADD and anxiousness, and my doctor prescribed Wellbutrin. He said it's primarily for the distraction and all of that, and that it can help sex drive. Do you agree with that? And is that one? So what would you tell women who are like, I'm anxious, I'm distracted? What would you give them if you did not
Yeah.
want to decrease?
Yeah, FDA has approved Wellbutrin for the treatment of sexual dysfunction and low libido in patients who are premenopausal, and I think it's a great medication. I think that's a wonderful recommendation as well.
Mhm.
And that's one of those in that class of medications that actually, thankfully, is beneficial for that. So we do have something to provide. I think too, I said at the beginning, it's multifactorial. So you have to think, oftentimes you got to think about their past history. Has this individual been sexually abused in the past?
Yeah.
People who have been sexually abused have a significantly higher risk or rate of having sexual dysfunction as they get older. Also, too, depending on how they grew up with their religious beliefs or how their family raised them, there's a lot of kind of that in the background that could affect. And then I think, a great option for patients who are premenopausal and struggling, I think referring to a sex therapist is a fabulous idea that can help patients understand maybe why they're experiencing what they're experiencing. And so, it takes a lot of time spending with those people. You have to really identify what the problem is, because it is a lot of different issues. There could be pain, there could be pelvic congestion, there could be pelvic muscle defects that could be leading to just they're not wanting to. There could be body perception issues. I mean, a lot of things. If a woman doesn't feel sexy or if a woman doesn't feel attractive, then the last thing she's going to want to do is engage in any type of sexual activity. And so I think it's also important, especially for moms who are really busy in life and they're taking care of their kids. They're trying to be a mom, they're a wife, they're doing all of the kind of things that they do, whether they work or don't work. They're just tired, just fatigued and tired. And I think a lot of what we've lost in the busyness of our lives is those little moments to capture with our spouses where we can go break away from the kids and go on a date or go on a small little getaway and recapturing kind of the relationship and the romance that still is in marriage and continuation in the dating process of your spouse. And so I think that's something that's very important. I think goes unrecognized a lot of times, kind of the elephant in the room many times. But yeah, there's a lot of different things to address when it comes to premenopausal, and that would be really individualistic and depending upon what their primary complaints are, to be honest with you.
Okay, now I want to ask you, just because I know there are going to be women saying, where can you find a sex therapist? Now,
Yeah.
and I would assume they are not going to address the physical as much as the emotional and are there a lot of those, and how do you find a qualified one?
Yeah, I think you can ask your physicians. I think we have a list of some even within our, we're thankful to have a pelvic pain specialist within our practice that actually deals quite a bit with sexual dysfunction in relation to pelvic pain. And there's pelvic floor physical therapists, if that's the problem, which are fabulous, and they work wonders. But there are recommendations that likely your physician could have, or you can get online yourself without even a referral, and you can kind of Google one in the area. In most cities, most places are going to have a licensed sex therapist or someone who's a therapist, but also does sex therapy on the side as well, and kind of are dual trained. And so, that's something easy that the office can help you with, your physician can help you with, or you can get on and kind of take the initiative and look it up yourself as well.
Okay. And I'm going to, because I know you have limited time, but I'm going to shoot some of these questions off, and you can either, if you just have a favorite or a recommendation.
Okay. Yeah.
Hair loss help for 60-year-old female.
Man, I think hormone replacement therapy is a questionable thing. I think you want to look at their thyroid. I think you would certainly want to do a thyroid study. And if I have patients that are really losing significant hair in a postmenopausal patient and it's becoming bothersome and noticeable, and they have normal endocrinology lab work, and maybe they're already on hormones, I might put a referral into like a dermatologist or someone to evaluate them further. Or even a rheumatologist can come in handy in those situations as well.
Mhm. Well, and I'm going to throw in, I have thyroid issues and I have very thin hair. And I will just tell you, hair extensions are wonderful.
That's
I
right.
have them. Many of my friends have them because it's normal for a lot of us, and they're fabulous. So that's just my 2 cents.
There
Okay,
you
and I
go.
had some younger ones, young marrieds asking about non-hormonal birth control, natural
Yeah,
family planning,
sure.
and does it really work? And if you had to recommend something non-invasive for those people who might
Yeah,
want to have a little more protection, what would you recommend?
sure. Yeah. So there's actually a newer product out right now called Phexi, a Phexxi, I believe it's how it's spelled. It's actually a gel, almost like a spermicide that you can take 30 minutes before intimacy, and it can neutralize the sperm and prevent pregnancy. It's actually been proven to be quite effective. That's a good non-hormonal option that people can look into. It's relatively new on the market, probably over the past 2 years, at least that's how long I've been aware of it. There's copper IUDs, which are intrauterine devices that are non-hormonal that last for 10 years. Those are options that are obviously they're more invasive because it's an intrauterine device that must be placed within the uterine cavity, but it doesn't have any hormones and it can be effective at birth control. Very effective at birth control. Now, a lot of folks have concerns over like intrauterine devices such as like your Mirena or your Kylenas or your Lilettas, which are those 5 to 7 year intrauterine devices. I want to make clear, these are localized hormones to the uterus with extremely low levels of systemic absorption. And so a lot of people come in like, I want a hormone-free option. And these are as close to hormone-free systemically as you can get with very limited side effects that we see clinically. And they can be extremely helpful for not only pregnancy prevention, but also bleeding help for abnormal uterine bleeding and what we call menorrhage or heavy cycles. These can significantly improve bleeding. If not completely eliminate bleeding after 6 months, it can significantly reduce it. And so those are kind of my top tier recommendations. Natural planning, it is good if you are responsible and you can do it, but that takes a lot of discipline, and so not always the most reliable thing. It can be very difficult to do that and to predict that, especially in a patient who might be breastfeeding. Because if you are breastfeeding, then you are likely to ovulate, and you're not going to have your cycles. And so you're going to be ovulating. You can conceive, however, you won't be having menstrual cycles to kind of time that up well. And so that would be difficult. But people do it well, and they've done it for a long time. And so.
Is an IUD, because I know a lot of people say that an IUD, that the sperm and the egg have gotten together, it just doesn't let it implant, and they feel like that's a religious thing.
Yeah, sure. No, and I don't place copper IUDs, and I think there's a lot of debate on that. To be honest with you, what you just said, I don't place copper IUDs for that reason, because there's thought that there is implantation of the sperm into the egg. And that's a fertilized egg that ultimately doesn't have a place to implant itself. Some would disagree with that. And I think there's some evidence that would argue the opposite of that, where that's not true. I think more so with the hormonal levonorgestrel, it causes cervical mucus thickening. It prevents ovulate. It's supposedly supposed to prevent ovulation, and it helps prevent sperm from actually reaching the egg, and therefore fertilization actually doesn't occur. At least that's what I've read, and that's what we as a practice have come to understand about that particular IUD. So we really don't do copper IUDs in our office for that reason, but we do, however, do your Kylenas, your Mirenas, your Lilettas, and those because of what you just mentioned.
So a woman can be very clear just about it if she discusses with her physician.
That's right. Yes, ma'am.
If you want to tackle dryness without hormones, would that be you get it at the drugstore, or what would you recommend?
Yeah. So
I don't want any hormones.
Without any type of hormones. You want a water-based lubricant. So water-based lubricants are very helpful There are a lot of products on the market that are not in the woman's best interest for the treatment of vaginal dryness with intimacy. Some of these are going to be more, they have a little bit more of an alcohol base to them. Some of the KY jellies, like the warming and cooling, they're not good for vaginal dryness.
They have alcohol that is drying. Yeah.
Well, it is. There can be low amounts of that. So you want more of a water-based lubricant, and the water-based lubricants are less toxic kind of to the drying out of the cells of the vagina. And there's a bunch of different ones. It's always one of those things. I tell patients, go on Amazon if you would like to. You don't want to see your best friend in the line at Walgreens or wherever, and you're buying lubrication or whatever it may be. But there's some great water-based lubricants. Some would say coconut oil. Some would say even like an olive oil, something like that are relatively low risk to patients. They're a household product. They're cheap, and they can be hydrating to the tissue. And so those can be something that women can try as well that are helpful if they want to avoid hormones.
Okay. I want to bring another one up in your opinion. And one of my best friends who's a physician, she uses this. She doesn't want a lot of hormones either, but I think it's low. Estrase.
Yeah.
And I've got some, but Dr. Banks said, don't use that. And the Intrarosa.
Atrosa. Yeah.
But, and I know my friend, he also recommended that you just put a little bit on the tip of your finger and just put it at the very opening of the vagina. Is that a low hormonal, even though it is hormonal, is that a safer way to?
Yeah. And like we mentioned earlier, I mean, vaginal estrogen replacement is a very low risk thing because of the limited systemic absorption. I mean, there's very, very little. So whether that's just a little bit that you put on your finger and place it at the vaginal opening, or if you use the applicator and you place it all the way within the vagina, either route or whatever you're comfortable with estrase or Premarin cream. Estrase is typically I usually use that 3 times a week. Whereas Premarin, I usually do it twice a week. And so, I mean, I think however you would like to do that is fine. I usually just say use the applicator, place it within the vagina, and do that 3 times a week. Do it at nighttime before bed, put a panty liner on and let it get absorbed into the vagina.
Okay. And then I just have 2 more. I'm 34 TTC. Have done IVF 3 times, bless her. We did it twice. What supplements to take for diminished ovarian reserve?
Oh man, supplementation for diminished ovarian reserve. I don't necessarily know of any proven literature that's going to say with good studies that are going to show significant improvement in an ovarian reserve if someone's anti-Mullerian hormone or AMH levels low. I don't know. I don't know if there's anything that I can strongly recommend based off of studies. Now, I think the reproductive endocrinologist that individual may be seeing could play into that maybe more successfully than I can.
Yeah.
But that's a tough deal. I wish you the best of luck, whoever asked that question.
I know we had 2 attempts, and the second one worked, praise the Lord. But okay, last one, is creatine beneficial or harmful for women to take? Now, I've heard of creatine, and I know it's what, do you know anything about that?
Yeah, creatine help. Yeah, so as our muscles, as you exercise and work out and you break down muscle tissue, when you replenish that with creatine, it helps rebuild those muscles. It kind of helps rebuild those back up. So it's a good supplement for people who are into weightlifting or exercising, CrossFit, HIIT therapy or HIIT training. And so, and the question was, does that affect negatively?
It just says, is it beneficial or harmful for women to take?
No, I don't think so. I think there can be a little bit more, creatine can cause a little bit more capturing of water within the cells. And so you can experience a little bit more bloating or maybe some weight gain with the creatine. But no, I think it's a great supplement. I think a lot of folks who exercise with creatine or use it as a supplement with exercise benefit greatly from it from strength and conditioning standpoint.
You have given me so much of your time today, and I'm very grateful for all of this. Before we sign off, is there any last bit of advice that you would have for women? Because there's so many different things and, so many different issues.
Yeah, it's, I think I think because studies have shown that sometimes physicians aren't the best at bringing these things up, especially when it comes to sexual dysfunction. Something that we really didn't touch on much was, prolapse, pelvic organ prolapse, urinary incontinence or fecal incontinence, these things that women can experience, especially as you get older. Studies have shown that physicians don't do a great job of bringing these things up in the office out of fear for time, in conversation and being on a time crunch, but also maybe not being knowledgeable about it or not wanting to speak about it or ask about it because it's an annual or something. Bring these concerns up to your physician. Sexual dysfunction is something that's very common. There's so many different avenues that need to be addressed there and evaluated to improve your overall quality of sex life. And then when it comes to menopausal symptoms and vaginal dryness, and these are things that are very treatable and that need to be addressed in the office and with your physician. And so don't be ashamed or embarrassed to bring them up. They're very common. Many patients experience them, and they're treatable. And we love to help people improve their overall quality of life. And lastly, for young or married people who have kids, as I mentioned earlier, date each other, go and enjoy the fruit of marriage and the fruit of being together, and take those times away from your kids. They will benefit from that greatly when you are able to take those moments and go spend with your wife or your husband, and then go on vacations together, go do things together. And it's harder when they're really young, but try to make it a priority, and it'll benefit your relationship, but it'll also benefit your children as well as you go forward.
Oh, I couldn't agree with that more. As an older mom, I totally agree with that. But
yeah.
Thank you. And last question: are you accepting for Birmingham women? Or are you accepting new patients?
Absolutely. We're
Okay.
at OBGYN South. We're at Brookwood. We occupy really the entire 4th floor of the Women's Health Center right there at Brookwood, and excited to meet any new patients. Yes, ma'am.
Okay. Well, thank you again, Dr. Aldred, and I just appreciate it. I'm sure be asking you to come back for more conversation.
I would love to.
Okay.
Thank you.
Thank you so much.